Glycopyrrolate, also known by its trade name Robenal, is a synthetic anticholinergic drug that is frequently used in anesthetic practice for a variety of reasons. You would typically find IV solutions supplied at 0.2 mg per ml in a 1 ml vial, which will look very similar to the picture on this slide. You may also find glycopyrrolate supplied in a 0.4 mg per 2 ml vial or a 1 mg per 5 ml vial. However, this is not as common. But do take note that in each instance the concentration remains at 0.2 mg per ml, regardless of how it is supplied. An important aspect of glycopyrrolate is that it is a polar quaternary ammonium salt, meaning its structure carries a charge and is therefore unable to cross the blood-brain barrier, limiting its central nervous system effects. This is unlike other common anticholinergic agents such as atropine and scopolamine, which are nonpolar tertiary ammonium compounds that can cross the blood-brain barrier and can result in profound CNS effects at sufficient doses. For comparison, I have juxtaposed the structures of glycopyrrolate and atropine sulfate on this slide. Notice how glycopyrrolate carries a charge, whereas atropine is uncharged. Another important aspect of glycopyrrolate is that it has a very low mean volume of distribution of approximately 0.42 liters per kilogram, which confines the drug to the plasma and interstitial spaces as opposed to the fatty and other body compartments. The mechanism of action of glycopyrrolate is very similar to other common antimuscarinics such as atropine in that it works by competitively antagonizing acetylcholine at postganglionic muscarinic receptors. These receptors are found in abundance throughout parasympathetically innervated tissues such as the sinoatrial node and bronchial smooth muscle. Muscarinic receptors are also found in tissues not associated with the parasympathetic nervous system, as is in the case with sweat glands. Now, while there are at least 5 identified major subtypes of muscarinic receptors, which are labeled M1 through M5, the mechanism of action relevant to achieve clinical endpoints of glycopyrrolate is principally associated with M1, M2, and M3 receptors. What is important to note here is that glycopyrrolate will competitively bind to each of these muscarinic receptors without preference, meaning that it will equally block peripheral M1, M2, and M3 receptors at any clinical dose. Okay, so remember that glycopyrrolate works by competitively binding to muscarinic receptors, which in effect means that it is just blocking the effects of acetylcholine, therefore preventing acetylcholine from doing its job. In other words, glycopyrrolate doesn't actually do anything once it binds to the muscarinic receptors. It just sits there like a key that fits into a lock, but can't actually open the door. So to fully understand how glycopyrrolate achieves its clinical effects, we must first understand acetylcholine's effects at the various muscarinic receptors. The most important aspect about muscarinic receptors is that they are all G-protein coupled receptors, which can be classified as either stimulatory or inhibitory when acted upon by acetylcholine. M1 and M3 receptors are stimulatory GQ G-protein coupled receptors, and M2 receptors are inhibitory GI G-protein coupled receptors. As discussed on the next few slides, these G-protein coupled receptor categories have important implications on the overall effect of acetylcholine on target organs and, more importantly, how glycopyrrolate will alter the end response. As previously mentioned, M1 and M3 receptors are stimulatory GQ G-protein coupled receptors. When acetylcholine binds to these receptors on a cell's surface, it activates a cascade of intracellular responses that ultimately leads to an increase in calcium. As you can see from the diagram on the right, this is achieved by the activation of phospholipase C, or PLC, which cleaves inositol triphosphate, IP3, and diacylglycerol, DAG, from the cell's phospholipid bilayer. IP3 in particular will travel to the sarcoplasmic reticulum and modulate the release of calcium. The released calcium can now participate in a host of physiologic activities including salivation, smooth muscle contraction, and pupil constriction. A very important concept here is that acetylcholine directly opposes sympathetic activity, that is, it opposes the effects of epinephrine and norepinephrine. Clinically, activation of M1 and M3 receptors can result in undesirable effects such as bronchoconstriction and excessive oropharyngeal secretion. Now, contrary to M1 and M3 receptors, when acetylcholine binds to M2 receptors, the result is an inhibitory response via the GI G-protein coupler receptor. This again leads to a cascade of intracellular responses, but in this case it depresses intracellular activity. As you can see from the diagram on the right, This is achieved by a reduction in the activity of adenylate cyclase, or AC, which results in a reduced rate of conversion of ATP to cyclic AMP, CAMP. Without CAMP, protein kinase A, pKa, the activation of it is diminished and ultimately results in reduced cellular activity. Again, a very important concept here is that acetylcholine directly opposes sympathetic activity. That is, it opposes the effects of epinephrine and norepinephrine. Empirically, this is implicated in cardiac deceleration, and there is a large concentration of M2 receptors on sinoatrial myocytes. Now that you understand the basic physiology of acetylcholine on various muscarinic receptors, it should be relatively easy to understand and predict what the clinical effects of glycopyrrolate will be. Remember, glycopyrrolate has no activity at the muscarinic receptor. It merely blocks acetylcholine from binding. What does this mean in terms of parasympathetic activity? Well, its overall effect is diminished, which leaves a relatively dominant sympathetic nervous system, that is epinephrine and norepinephrine, and this is generally the clinical effect you see, a dose-dependent parasympatholysis. Please note that glycopyrrolate will not bind to nicotinic receptors, which are also acetylcholine receptors, and therefore will not interfere with the neuromuscular junction. Also note that sweat gland activation is a function of acetylcholine released from the postganglionic sympathetic innervation. The action of glycopyrrolate on sweat glands can therefore be considered a sympatholytic in this isolated circumstance. We've been discussing the effects of acetylcholine on muscarinic receptors and the pharmacodynamics of glycopyrrolate for the past several minutes. So to put it all together, the next few slides will briefly animate what you have just learned. The next several slides will discuss the usual dosing and pharmacokinetics of glycopyrrolate. The typical dose for anti-sialagogue activity and to treat intraoperative bradycardia is 0.4 micrograms per kilogram. For each 1 milligram of neostigmine, a dose of 0.2 milligrams of glycopyrrolate is administered mixed in the same syringe to counteract the cholinergic effects of neostigmine. Neostigmine is an acetylcholinesterase inhibitor used in the reversal of non-depolarizing neuromuscular blockers. The onset of intravenously administered glycopyrrolate is within 1 minute. If administered intramuscularly, as is commonly done in pediatric anesthesia, the onset is typically 15 to 30 minutes. Intravenously administered glycopyrrolate will peak within 5 minutes, whereas intramuscular injection of glycopyrrolate will peak within 30 to 45 minutes. The duration of action of glycopyrrolate largely depends on the clinical effect. Vagal blockade will persist for up to 2 to 3 hours, whereas anti-sialagogue activity will persist for up to 8 hours, which is superior to atropine lasting about 3 to 4 hours. The T1/2 beta, which corresponds to the drug's elimination half-life, is about 45 minutes. Considering that a drug should be effectively cleared after 4 to 5 elimination half-lives, which roughly corresponds to glycopyrrolate's vagal blockade, an extensive literature search did not reveal why glycopyrrolate exerts anti-sialagogue activity for up to 8 hours. Glycopyrrolate seems to undergo little metabolism, as 80% can be recovered unchanged in urine and in bile. This suggests glycopyrrolate is largely excreted hepatorenally. There are several anesthetic indications for the use of glycopyrrolate during the perioperative period. Glycopyrrolate is a potent anti-sialagogue via blockade of M1 and M3 receptors. It is given to dry upper airway secretions prior to intubation, before bronchofibroscopic procedures, and before oropharyngeal surgeries. It is also given to counteract the hypersalivation effects of ketamine. Glycopyrrolate is also given to counteract intraoperative bradycardia, that is generally a result of vagal activity. Here the effect is via blockade of M2 receptors, allowing for sympathetically dominant tone. Another important use of glycopyrrolate is to counteract the effects of neostigmine administration. Neostigmine inhibits acetylcholinesterase, the enzyme responsible for breaking down acetylcholine. This enzyme inhibition leads to an increased level of acetylcholine, which is desired to reverse the competitive blockade of non-depolarizing neuromuscular blocking agents at postganglionic nicotinic M receptors. However, the increased levels of acetylcholine will also activate more muscarinic receptors than desired, resulting in bradycardia, hypersecretions, and potentially untoward smooth muscle contraction. Glycopyrrolate will block muscarinic receptors, but remember, not nicotinic receptors, and mitigate the undesired responses via M1, M2, and M3 receptors. Finally, glycopyrrolate has the potential to, at least theoretically, prevent parasympathetically mediated bronchoconstriction. Contraindications to the use of glycopyrrolate are generally relative and include hypersensitivity to the drug or any of its inactive ingredients. Tachycardia, obstructive uropathy, and glaucoma are also contraindications. This is because glycopyrrolate will block acetylcholine at muscarinic receptors, which will tend to exaggerate conditions where acetylcholine is necessary. M2 blockade will worsen tachycardia, whereas M3 blockade will worsen obstructive uropathy due to inhibition of bladder contraction. M3 blockade in glaucoma will lead to pupil dilation and therefore closure of the anterior chamber drainage angles. The main untoward effects in these instances is the result of relatively unopposed sympathetic stimulation. Well, that wraps up this discussion on glycopyrrolate. Hopefully it was informative and that you have a better understanding of how it works. The final two slides contain links to further reading about glycopyrrolate and the references used to produce this lecture. Thank you and have a great day.